Good evening, everyone. We welcome you all to PRAGNAVARIDHI lecture series conducted for first year BMS. Today we have Vaidya Sajina ma'am, before which I'll give a short introduction to Panchajanya. Panchajanya, the divine couch of Bhagavan Sri Krishna, which was blown during Kurukshetra, indicating the start of Dharma Yuddha that followed. All the efforts were done for the establishment of Dharma. Dharma was kept over personal interests, agendas, and motives. Keeping the same motive in our mind, our organization will work towards establishing the importance and necessity of following and imbibing Bharatiya culture, accepting our roots, and making people realize the true essence of Ayurveda, not only as a treatment modality but also as a way of life. Shreyam Bharatiyam, Arogyam Ayurvediyam. The founders of this organization started this because we wanted to spread the knowledge of Bharatiya culture, Ayurveda, the true history of Bharata Rashtra, and values to all the strata of people in every corner of the world. Also, founders being Ayurveda aspirant know the inside workings of today's medical field. Hence, they aim to make people aware of this and also try their best to solve this in one go. With this aim in mind, I would like to welcome you all to Pragnavaridi lecture series conducted for first year students. Today we have Vaidya Sajna ma'am. Ma'am has completed her UG in JSS Mysore and PG in Alvas Mudbidre. Ma'am has a teaching experience of 3.3 years. Ma'am has presented many papers in national and international conferences. We welcome you, ma'am. Handing over the session to you.
Thank you, Pratiksha. Thank you for the introduction. Good evening, one and all. I would like to thank Panchajanya team for their giving me this opportunity, this platform, and I appreciate them because they are conducting classes, guest lecture series for exam going batch. Even last year also they conducted. So I appreciated the total team Panchajanya. Okay, so we will start the section. Pratiksha.
Yes, ma'am.
Okay, thank you. So, moving to today's section, that is today's topic, eyeball. As per NCISM, this eyeball, Kala Shareera, Indriya Shareera, these all will come for 20 marks, and you can expect any one question, any one sense organ as LAQ or MCQ or SAQ. So, any type of question you can expect from this eyeball. So, coming to this topic, eyeball. The eye, it is a special sense organ for the power of sight. Okay, the shape of the eyeball, it is not exactly the spherical shape, because many textbook you can see it is sphere in shape, because it is an oblate spheroid shape. As the diagram you can see, that is not exactly sphere, it is a oblate spheroid shape. Coming to the location where it is situating, the eyeball which is situating into the orbital cavity, it is also known as eyeball or globe of the eye. And this orbital cavity, as you already studied in osteology, it consists of boundaries like roof, wall, medial, lateral wall. And this orbit, the main content of the orbit is eye and its vessels, nerves, and also its extraocular muscles, along with some amount of fat. This fat, which will help for, it will give the cushion effect to the total eyeball, and it will prevent the external injuries too. And this total eyeball, which is covered with a capsule, it is known as tenons fascia or fascia bulbi. Because of this capsule, this eyeball, which is moving very easily, smoothly moving inside the orbit. And coming to this eye, it is divided into two segment of spheres. That is, anteriorly there is a small segment that is known as cornea, that is only 1/6 of the eyeball, and posterior it is very large sphere, that is sclera, this posterior 5/6. So coming to the dimension of an adult eyeball, normal you can tell it is 2.4 centimeter or 24 millimeter. If you take individually, That is anteroposterior diameter is 24 millimeter, horizontal diameter it is 23.5 millimeter, vertical diameter is 23 millimeter, circumference 75, volume 6.5 ml, and weight is 7 gram. Why this diameter? What is the importance in clinical aspect? Because if the diameter, if it is normal, you can see there are three diagrams. In first diagram, if the diameter is normal, that is 2.4 centimeter or 24 millimeter, what will happen means the parallel rays which is coming from infinity, and it will pass through refractive medias, that is first one cornea, then aqueous, then lens, then vitreous, then it will reach into the retina. So if the eyeball size is normal, that is 24, then the rays coming from infinity, it will focus retina only, so the person can see very perfectly. If the eyeball which is large, what will happen if the diameter is more than 24 millimeter, that is up to 29 or 30, the rays which is coming from infinity, it will focus in front of the retina. In such condition, the person cannot see the distant things, distant object, that is known as nearsightedness vision. So this can be also it is known as myopia, and this can be corrected with the help of a myopic glass, that is convex concave lens. And one more condition, if the diameter is less than 24 millimeter, that is it is 20 or below 20, the eyeball size it will become small, and the parallel rays coming from infinity, it will focus where? Behind the retina. In myopic condition, it is in front of the retina. This is behind the retina. In this condition, the person cannot see the near object, and that is known as far-sighted vision. And this can be corrected with the help of a convex lens. So these are known as myopia, hypermetropia. These all are known as refractive errors. So that is the importance of dimension. One should have normal dimension, they can see properly. If it is more, and that condition is known as myopia, and if it is less, that is known as hypermetropia. So remember these dimensions, they may ask as MCQ. Next is the codes or tunics of the eyeball. It is also known as layers of the eyeball. This is very important because eyeball, it is oblate spheroid shape. It consists of three layers. So the first layer, it is known as outermost layer. It is fibrous cord. Middle one, it is vascular cord. It is also known as uveal tract. And the innermost layer, that is known as nervous cord. We will see one by one. The fibrous cord, because it is very outermost layer, so it is very strong, dense fibrous tissue. And it consists of two structures, that is already in first slide I mentioned, that is anterior 1/6, that is known as cornea, it is very transparent, and posterior large area, that is known as sclera, that is the posterior 5/6 area. And this cornea which is attached into the sclera just like a watch glass, and there is a junction in between this cornea and sclera, that is known as limbus or sclerocorneal junction. And also one more transparent structure, that is conjunctiva, it is firmly attached to this limbus, and that is known as bulbar conjunctiva. So this is about fibrous, outermost fibrous cord, and there are two structures, that is sclera and cornea. Coming to the middle or intermediate structure or layer or tunics, it is also known as vascular cord or uveal tissue. This is completely made up of pigments, that is pigmented, and it have many nutrients. It supplies the nutrition because it consists of many vessels. Okay. And this consists of again three parts. They are from anterior to posterior. Three parts are there, that is iris, ciliary body, and choroid. We will see later this detailed description. Coming to the innermost layer, that is very delicate structure, that is known as retina. It is the nervous cord, and it is very thin, and it is concerned with the visual functions and projection to visual cortex through the visual pathway. So you already studied the visual pathway in your Kriya, Shareera and nervous system. Physiology and nervous system, that is nothing but retina, the images reaching retina from their optic tract, lateral geniculated body, visual cortex, that is. So this how the image is forming, where the image is forming, all this depends upon this nervous cord. And retina is an example of a moving brain. Why it is? Because retina is derived from part of brain that is diencephalon. So that's why the retina is known as it is a moving brain. Similarly, the choroid, which is derived from the arachnoid and pia mater, and sclera, which is derived from the dura mater. So this is the three cords or tunics of the eyeball. Remember, the outer fibrous cord, it is consist of it comprises that is the sclera and cornea, and middle vascular or uveal tissue, it consists of iris, ciliary body, and choroid, and the innermost layer, that is nothing but retina. Coming to the individual description, that is fibrous cord, outermost fibrous cord, that is anterior 1/6 is cornea and posterior 5/6 the large area, that is nothing but sclera. We will discuss first sclera. Sclera, as the name mentions, sclerose, that means which is very hard. It is very hard, opaque, and it is made up of dense fibrous tissue. Why it is? Because it is giving protection to remaining structures. And also it will maintain the shape of the eyeball and the maintenance of intraocular pressure also by with the help of sclera. What is intraocular pressure? The pressure which is inside the eyeball. If it is more or any obstruction to this aqueous flow, which may leads to other clinical condition that is known as glaucoma. Sorry. This sclera, which has thickest and thinnest part. Thickest part is very near to the entrance of the optic nerve, where the optic fibers are passing, and because of that only this area is weakest. Why this? Because these fibers passing inside and outside, that time there will be formation of many openings, and that openings is just like a sieve, and that is known as lamina cribrosa. It's nothing but the passage of optic nerve fibers. That's why this area is thickest, but it is weakest. And coming to the thinnest part, it is just 6 millimeter behind the limbus, where the recti muscles, are nothing but it is the extraocular muscles. There are 4 recti muscles which will help for the movement of the eyeball. So where the recti muscles are inserting, that area just behind the limbus, that area is very thinnest area of the sclera. And the junction between sclera and cornea, it is known as limbus or sclerocorneal junction. And just behind this sclerocorneal junction, there is a circular canal. And that circular canal, it is known as canal of Schlem or sinus venosus sclera. So the function of this canal, it will help for the drain of the aqueous humor and nourishing the cornea and remaining structures. That is about limbus and canal of Schlem. And one more triangular projection in the sclera medial to the canal of Schlem, that is known as scleral spur, sclera spur or scleral spur. And this total sclera, which is covered outside with a white smooth covering, that is known as Tennant's capsule or fascia bulbi. And this sclera, which is outermost, after that which is next is vascular layer, that is nothing but choroid is starting. So in between this sclera and choroid, there is a space that is known as perichoroidal space or lamina fusca or suprachoroidal space, suprachoroidal lamina. So these are the structures which is present in the sclera. And coming to the structures which is piercing the sclera, many structures are piercing the sclera, especially optic nerve. That's why I told already the posterior part which is very thickest and weakest. And also extraocular muscles, then ciliary nerves and arteries, anterior ciliary arteries, and especially there are 4 venae verticosae, it is also known as choroid vein, which will give the nourishment to the total eyeball inside. And sclera is very less vascular, and the space between sclera and conjunctiva, that is made up of loose connective tissue, and that is known as episclera, and it is avascular. Structurally, sclera consists of 3 layers. That is nothing but episcleral layer, substantia propria, and lamina fusca. So this is about the outermost fibrous cord sclera. Coming to the next coat, that is cornea. Cornea, it is the anterior one-sixth of the outermost covering or tunics, and this cornea is very transparent and avascular. Because of this avascular, what is the meaning of avascular? It is absence of blood vessels. The cornea is transparent. And other important things are the arrangement of uniform arrangement of collagen fibers and nature of the ground substance. This all makes the cornea become transparent. Even though it is transparent, but it is sensitive to touch and pain because it is supplying by ophthalmic nerve. And this cornea is avascular. Then from where it is getting nourishment? It is getting nourishment from aqueous humor behind and lacrimal fluid which is present in front, and some periphery portion which is getting nourishment from the diffusion from the capillaries. So these all aqueous, lacrimal fluid and diffusion from capillaries, these all makes the uh, avascular cornea will become nourishment through these all uh, structures. Coming to the how the cornea is situating over the sclera, it is just like a watch glass, and the junction we already told in the sclera section, that is the junction between cornea and sclera, it is known as limbus or sclerocorneal junction. And this, there are mainly four refractive index. First is cornea, then aqueous will come. You can see in that diagram. First cornea, next aqueous, then third one is lens, fourth one is vitreous humor, then last it will reach into the retina. So here the maximum refraction of light take place in the cornea only, because its refractive index is 1.376 and refractive power is 45 diopter. Even this lens, its dioptric power is 15 diopter, but cornea has more, that is 45 diopter. And as age advances, the corneal curvature, it will start to diminish as age advances. And the corneal curvature is convex than sclera, but as age advances, this convexity will become decreasing. And the thickness of the cornea is center, it is 0.5 to 0.6 millimeter, periphery it is 1 to 1.2 millimeter. And one condition, you can see one refractive error. Nowadays it is very common, that is nothing but astigmatism. That is, the cornea is more curved in one meridian than the other. If it is happen, the cornea is curvature is irregular, then the light rays, it will focus in different places of the retina, and that condition is known as astigmatism. And we can correct this astigmatism with the help of a cylindrical glass. So this is about cornea structure. Coming to the uh, microscopic structure of the cornea, it consists of 6 layers from anterior to posterior. We can see first layer, that is epithelium. It is made up of stratified squamous non-keratinized epithelium. And after epithelium, this epithelium which is rest on the next layer, that is known as Bowman's membrane. It is also known as anterior elastic lamina. This Bowman's membrane, once it is damaged, it won't regenerate. And the third layer, that is substantia propria. It is also known as corneal stroma, which is made up of collagen fibers. It is maximum amount, you can see the substantia propria only. And the fourth layer, just in front of the next, that means fifth layer is Descemet's membrane. So in front of Descemet's, that it is known as pre-Descemet's membrane or Duas layer. Dua is the scientist's name. And the fifth one is Descemet's membrane. It is also known as posterior elastic lamina. It is elastin, not elastic fibers. And it will help for the cornea to maintain its curvature. The last layer, it is known as endothelium. It is simple squamous mesothelium. This endothelium which will help for the provide the metabolic exchange of the aqueous and cornea. So once again, these are the 6 layers of the cornea. First one, epithelium, Bowman's membrane, substantia propria, pre-Descemet's membrane, Descemet's membrane, and endothelium. Here Bowman's membrane, once it destroyed, it won't degenerate. But Descemet's membrane, unlike Bowman's membrane, it will regenerate. And endothelium is the last layer of the cornea. And once any damage to this cornea, this epithelium can be transplanted with the donor cornea, and that condition is known as keratoplasty. That is, cornea can be grafted from one person to another person, and that grafting procedure, it is known as keratoplasty. And this injury to the cornea, that is known as corneal injury, it leads to corneal ulcer. Later the corneal ulcer may leave a scar, that is known as corneal opacity, and these opacities which may interfere with the vision. And refractive errors is another one clinical anatomy of the cornea that we discussed already: myopia, hypermetropia, and astigmatism. These are the some of the clinical anatomy of the cornea. Coming to the sclera, clinical anatomy: inflammation of the sclera is known as scleritis, and the conjunctiva, it is known as conjunctivitis. That many of you experience the conjunctivitis, that is redness and itching and watering eye. It's nothing but the inflammation of the conjunctiva, that is very common. So this is about the outer fibrous coat or tunics, that is consist of sclera and cornea. And these are the important things. Here you can expect MCQ or 5 mark, that is explain the outer tunics of the eyeball. So you have to remember the layers of the cornea, and the thickness of the cornea, and sclera, in that what is junction between cornea and sclera, that is nothing but limbus, and canal of Schlumpf, sclera spur. These all you should remember. May ask as MCQ. Next we will move to the intermediate layer, that is nothing but uveal tract or middle coat. This is consist of three structures from anterior to posterior, that is iris, ciliary body, and choroid. First one is choroid, that is very posterior, that is situating in between retina and sclera. So it is a sandwich in between retina and sclera. That structure is known as choroid, which will give the nutrition to the remaining structures. Why? Because this choroid, um, which consists of many vessels. That's why it is giving nourishment to the remaining structures, and it is a pigmented layer. And the main function of the choroid is, if there is an excessive light rays passing to the eye, that time these pigment which will absorb the unwanted rays, and it will avoid the reflection. So that is the main function. And one more, it is the nutrition which is supplying to the total eyeball. So it is extend from optic disc to ores areata. That means outside it is sclera and inside it is retina. So from retina, that is optic disc, to ores areata, that is nothing but the optic part of retina forms a wavy line, that is known as ores areata. So up to here it is extending. And the inner surface of this choroid is very smooth, and it is brown in color, and the outer surface which is rough. Why? Because it is contact with the sclera. In between sclera and choroid, I already mentioned, that is there is a space that is known as lamina fusca or perichoroidal space. And structurally, this choroid, which consists of four layers, that is suprachoroidal lamina, that is the first layer, that which is attaching to the sclera. It is also known as lamina fusca. After the suprachoroidal layer inside, from anterior to posterior, that is next one is vascular lamina, which consists of mainly embedded with vessels, and after that the choriocapillary lamina, and the last layer, that is known as basal lamina or membrane of Brish. And this basal lamina which is adherent to the innermost retina. So this is about the structure of the choroid. Coming to the next structure, that is ciliary body. It is the thickened part of the uveal tract. It is situating just posterior to the limbus. That means in between choroid and iris. That is the anteriorly which is iris, and posteriorly with the choroid. And this ciliary body, this will help for the near vision. How? Means the ciliary body which consists of ciliary muscles. The ciliary muscles, the proper movement of the action of the ciliary muscles, which may help for the near vision, that is accommodation. And that's why the ciliary muscles are known as muscle for accommodation. And this ciliary body, which is triangular in cross section, and it consists of two parts. Anterior part, it is known as pars plicata, and it is rigid, and also it consists of many ciliary process, almost 70 ciliary process you can see there. The ciliary process which consists of the ciliary muscles, then ciliary process which will give support, it will support the lens to suspend there, and that will give provide attachment to the suspensory ligament or zonule of sync of the lens. And posteriorly, there is one more portion that is known as pars plana, and it is attached to the vitreous surface. It is very smooth and black. So in total, the ciliary body, which consists of two parts, that is pars plana and pars plicata. Pars plicata is the anterior part, and it consists of ciliary process, and the posterior part, it is known as pars plana, and it is attached to the vitreous surface of the eye. Okay. And this ciliary muscles, the ciliary body which is attached, which consists of ciliary muscle. The ciliary muscles, it is there are three types of ciliary muscles present in the ciliary body. They are longitudinal or outer or meridian, and next one is radial or oblique, and third one is circular. These are the three types of ciliary muscles present in the ciliary body. This outermost longitudinal layer type of ciliary muscle, which will help for the opening of the iridocorneal angle. And this opening, because of this action, there will be opening this angle, and there is the draining of the aqueous from posterior to anterior chamber. Next one is radial or oblique muscle, which will help for the distant vision, which will help for the flattening of the lens, and it will help for the distant vision. And third one is circular or innermost layer of the ciliary muscle. Due to its contraction, there will be accommodation and tension free of the lens, and it will help the lens become more and more convex, and which help for the near vision. So the second layer, that is oblique layer, which will help for the distant vision, and the innermost layer, that is circular layer, which will help for the near vision. That's why the ciliary muscles are known as muscle for accommodation. Coming to the clinical anatomy, uveitis, that is nothing but the inflammation of the uvea. And just now I explained how the muscles action. You can see in that diagram, when you are reading book, the ciliary muscles are contract. Which type of ciliary muscle? That is innermost ciliary muscle which start to contract. That time the suspensory ligament become more relaxed. You can see the first diagram, and that time the lens become more and more convex, and you can read the near objects, or you can read newspaper and all very easily. If you, that second diagram you just see there, if you look infinite, that time what will happen? The next middle layer, that is oblique layer, will act. That time the ciliary muscle is relaxed, and suspensory ligament, it is tense, and lens become flat. So that is the action of ciliary muscles. And here you have to remember, the muscle for accommodation is nothing but the ciliary muscles. So these are the clinical anatomy related to the ciliary muscles. And the third structure of this middle coat, that is iris. It is the anterior most part of the uveal tract. It is a diaphragm like structure, and it is just like a curtain. So in between there is a curtain, there is a small opening at the center, and that opening is known as pupil. This pupil will help for the regulation of the light which is entering into the eye. And this is vertically placed in between cornea and lens. That's why the iris, which is divide this anterior segment of the eye into anterior chamber and posterior chamber, and you can see there is a iridocorneal angle. Through that, aqueous is drained towards the anterior chamber. And this color of the eye, that's color of the iris, that is depends upon the number of the pigment cells present in the in its connective tissue. An example, if the color is brown, then there is more pigment. If the color is very like blue color of the eye, that means the iris is very pigment of the iris, that is very scanty. If it is white, mainly in albinism condition, that means there is no pigments at all. And there are two types of muscles which is present in the iris. One is sphincter pupillae and another one is dilator pupillae. This parasympathetic and sympathetic action will help for the pupil controlling the light rays which is entering. Means in dark the pupil will start to dilate, and in very light at daytime, that is the pupil will become constrict because of this sphincter and dilator pupillae action. So here you have to remember the color of the iris, which is depends upon the pigments cells in its connective tissue. If there is no color, that is white color, means there is no pigments. If it is brown, there is more pigment. If it is blue color eye, that means iris, that means there is a scanty pigment. So this is about iris. Coming to the segments and chambers of the eyeball. I mentioned in iris, that is how the iris is divided into the chamber. Before that chamber, we should know what are the two segments of the eyeball. So how the segment division, see in this diagram, there is a lens. This lens which is dividing the eyeball into two segments. Posterior to lens, that is vitreous body, that one segment, that is known as posterior segment of the eyeball, and anterior to this lens, that is the consist of iris, then cornea, all these things, which is known as anterior segment of the eyeball. Remember, there are two segments of the eyeball, that is posterior segment, that is behind the lens, and anterior segment is that is which is present in front of the lens. Again, this anterior segment, it is divided into two chambers. Here one more diagram is there, only focused into the anterior structures, that which is situating anterior to the lens. That is known as anterior chamber. This anterior chamber again divided into anterior segment, and this anterior segment again divided into anterior chamber and posterior chamber. First, we will see what is anterior chamber. The anterior chamber, the chamber which is located in between cornea and iris. That means anteriorly by the back of the cornea and posteriorly by the anterior surface of the iris and part of the ciliary body. That chamber is known as anterior chamber. It is almost 2.5 millimeter deep in the center, and it is very shallow, somewhat shallow in hypermetropes and deep in myopes. I told already in myopia that the curvature will means eyeball become more large than normal, that is more than 24 millimeter. That's why it is deep in myopes and shallow in hypermetropes, and it contains aqueous humor, that is 0.25 ml of aqueous humor. And this anterior chamber, it is communicate through the means behind posterior chamber is there through the pupil. Just now we discussed pupil, it is nothing but the central part of the iris. So through pupil, this anterior chamber and posterior chamber is communicating. Coming to the posterior chamber, it is triangular space which also contains aqueous humor, that is 0.06 ml of aqueous humor you can see in this posterior chamber, and the chamber which is situating in between lens and posterior aspect of the iris. Anterior aspect of the lens and posterior aspect of the iris. That space it is known as posterior chamber. So this is all about the anterior segment. Once again, remember, eyeball, it is divided into two segments, that is anterior segment and posterior segment. Posterior segment, that is behind the lens. The vitreous you can see, but anterior segment again it is divided into anterior chamber and posterior chamber, that is in front of the lens. This anterior chamber, that is in between cornea and iris, and the posterior chamber in between lens and iris. These both anterior and posterior chamber, that is total anterior segment which is filled with the aqueous humor, and posterior segment which is filled with the vitreous humor. So that is about the segments of the eyeball. Coming to the last coat or layer, that is known as retina. So this is very thin, delicate innermost layer, and outer side of this retina, it is attached to the choroid. that is brush membrane that is attached to the choroid, and inner which is attached to the hyaloid membrane. Hyaloid membrane is, there is a fossa, hyaloid fossa, and it is covered with hyaloid membrane, and inside you can see the vitreous jelly like substance, that is vitreous humor. And in this posterior pole of this retina, there is a circular area just 3 millimeter opposite to the entrance of the optic nerve, and 3 millimeter medial to the posterior pole. There is a circular area, and that is known as optic disc. This is very, very important. And the diameter of optic disc is 1.5 millimeter. And in this optic disc, there is a depression in the optic disc that is known as physiological cup or physiological blind spot. Why means there is absence of rods and cones. That's why it is known as physiological cup or physiological blind spot. And one more elevation, one more structure which is present posterior pole of the eye, just 3 millimeter lateral to this optic disc. This optic disc is just opposite to the entrance of the optic nerve. There is a depression, that is circular area, that is known as optic disc. Just lateral to this optic disc, there is one more area that is known as macula lutea. By the name means it is yellow in color, and there is a depression on the center of this macula lutea. It is very thinnest, and there is maximum acuity of vision because there are many cones, mainly the cones which is present in this area, and that is known as fovea centralis. So there are some areas which is present in the retina, that is first one is optic disc, and its diameter is 1.5 millimeter, and next one is this 3 millimeter lateral to optic disc. There is one more yellow spot that is known as macula lutea, and the depression which is present in the macula lutea, it is known as fovea centralis. And these consist of the retina which is consist of pigments like rods and cones, and the pigment which is present in the rod, it is known as visual purple, and this is only for scotopic vision. And the cones which is for photopic vision, that is color vision. And one more thing here, the parts of the retina, that is it is mainly divided into three parts: optic part, ciliary part, and iridial part. Optic part, it is up to ora serrata. I mentioned already, that is a wavy line which is present in the just near to the ciliary body, that is nothing but ora serrata. Up to that, it is known as optic part. Beyond that, that is non-nervous part, it is known as ciliary retina and iridial retina. And this total retina, it is supplied by central retinal artery. It is one among the end artery. So this is all about retina structures. Coming to the layers of the retina, there are mainly 10 layers of the retina. You have to remember the sorry, you have to remember the layer name. That is, first layer is pigment epithelium, next one is layers of rods and cones, and third one is outer limiting membrane, then outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, ganglion cell layer, nerve fiber layer, and last one is internal limiting membrane. Internal limiting membrane, that which is attached to the hyaloid membrane. And first one, pigment epithelium, and layers of rods and rods of cones, that is mainly for the pigments that is present in the retina for rods and cones, that is attached to the choroid. Remaining all for the nucleus and its cell body, all these things. So you have to remember the 10 layers of the retina name. This total retina may ask for 5 mark, that is SAQ question. So this is all about the uh, 3 codes or 3 tunings or 3 layers of the eyeball. Um, Beginning, we started there only, that is outer fibrous layer which consists of sclera and cornea. Next, middle vascular layer, that is also known as uveal tract. It consists of ciliary body, choroid, ciliary body, and iris. And the last one is retina, that is the innermost layer. It is also known as inner nervous cord. So this is the clinical anatomy of the retina. The retinal detachment is very common. The retina is detaching, some part of the retina is detaching from the cornea, and some part of the retina is detaching from the Hello, Pradiksha.
Yes, ma'am.
Continue.
Yes, ma'am. Can you
Okay.
share your screen, ma'am?
Yes, yes, I'm sharing. Some network issue happened in between. Sorry.
Yes, ma'am. It's visible now. Yes.
Okay, okay,
You can continue, ma'am.
okay. So these are the three codes or tunics of the eyeball we discussed. Now coming to the refractive media of the eye, there are mainly four refractive medias. First one is cornea, next aqueous humor, then lens, then last one is vitreous humor. So these are the refractive medias. Cornea and we explain very clearly. Now we will see the aqueous, lens and vitreous. So aqueous humor, it is nothing but a clear fluid which fills the anterior segment. Already mentioned how the anterior segment again it is divided into anterior chamber and posterior chamber. So this is secreted from this aqueous, which is secreted from the capillaries in the ciliary process, which is reached into the posterior chamber. Through pupil it will reach into the anterior chamber. From anterior chamber there is an angle, that is iridocorneal angle, and canal of Schlem is present due to the action of the intermediate layer of the ciliary muscle, that is oblique muscle, first layer of the ciliary muscle, that is longitudinal muscle, which help for the opening of the iridocorneal angle. Through this it will reach into the anterior ciliary vein and it will give the nourishment to the anterior most structure of the cornea. So this aqueous which is present into the anterior segment, that is anterior chamber and posterior chamber of the eyeball. If any blockage or any excess or less production of the aqueous, which may leads to one condition that is known as glaucoma. This also, if we are not treat properly, which may leads to visual impairment. Normal intraocular pressure range is 10 to 20 millimeter of mercury. If it is more than that, which may leads to glaucoma and optic disc cupping, all these symptoms will start. So this is about aqueous humor. Coming to the lens. Lens is the next refractive media. First one cornea. The rays passes through cornea, then it will reach into the aqueous, then it is reaching into the lens. This lens, it is transparent and biconvex structure. I already mentioned in cornea, that is the dioptric power of the cornea, it is 45 dioptric power diopter, and here lens it is 15. Total it is 60. In that 15 it is lens. So it can vary this dioptric power. And this lens which is suspended and properly situating into the eye with the help of some ligaments, that is known as suspensory ligament or zonule of C. This will keep the lens in flattened position and it is covered with the capsule, and the diameter of the lens which is 1 centimeter, and there are two poles, anterior and posterior pole. And the lens which is very transparent like cornea, so if anything happen to this transparency and it will become opaque, and that condition is known as cataract. And it is as age advances, this lens start to become more and more opaque, and that condition is known as cataract, and we can do surgical correction for this condition. So this is about lens. And last refractive media, that is nothing but vitreous body. It is a colorless jelly like transparent mass which is filled the posterior segment of the eyeball, not the posterior chamber. Remember, it is posterior segment, that is just posterior to the lens. It is enclosed with a delicate membrane that is known as hyaloid membrane, and which is attached to the innermost aspect of the retina. So in between optic disc and in front of oris areata, this vitreous body you can see. This will again, it will give the shape of the eyeball. These are the total structures and what are the refractive medias of the eyeball. Coming to the appendages of the eyeball, there are some small structures you can see, that is conjunctiva. We already discussed while explaining sclera. That is a transparent structure which is present over the limbus and which is present or into the eyeball eyelid also, and that conjunctiva it is known as that which is present inside the lid, that is known as palpable conjunctiva, that we can see exposure, that is known as exposed conjunctiva, that is known as bulbar conjunctiva, and the junction between these two, it is known as fornix, conjunctival fornix. These are the three types of conjunctiva, and any inflammation of this conjunctiva, it is known as conjunctivitis, we explain. Other extra appendage, it is eyelid, it is also known as palpebrae, which will help for the eye from external, like foreign body, excessive light, all this. Suddenly what we will do, we will close our eyelid. So eyelid, which will protect the total eyeball, and it consists of many glands like tarsal gland, apocrine gland, and sebaceous gland. Some names are meibomian gland, gland of Sees, gland of Mole. Any inflammation of these, any infection of these glands, which may leads to condition like chalazion. Second diagram you can see, and third one, that is stye. It is stye is painful condition, and chalazion, it is not a that much painful condition, and disfigurement will be there. And the treatment wise, you can do incision and the drainage of this uh, chalazion and stay. So this is about eyelid. Last one is lacrimal apparatus. Apparatus is nothing but group of structures. Like lacrimal gland is there. It has orbital and palpebral part. And next one is conjunctival sac. Lacrimal gland, which produce the lacrimal fluid, and it will reach into the conjunctival sac. There it will reach through the lacrimal punctum. Then common canaliculus, lacrimal sac. Through lacrimal sac, it will reach, and from there nasolacrimal duct, and it will reach into the inferior nasal concha. So this is the total, this structure, it is known as lacrimal apparatus. So any infection or any inflammation of this, any one of this structure, any blockage of any one of this structure, uh, which may leads to blockage of total this lacrimal outflow, and that condition is known as dacrocystitis. This is one more thing we have to mention, that is extraocular muscle. There are voluntary and involuntary. Voluntary, there are 7 muscles: 4 recti, 2 oblique, and 1 levator palpebral superioris. These have common origin, that is common tendinous origin, and which will help for the movement of the total eyeball. So that is all about eyeball. uh, it may ask for a long question or short question, or you can expect the MCQ. If long question, they may ask explain total eyeball. That time you have to give a small introduction to the eyeball, where is the location, what is the shape, dimension, all these things, and the detailed description of 3 cords or 3 tunics of the eyeball, and each and every structures which is present in each layer. Give small description, and along with the clinical anatomy. So you can include some of the extra appendages also. So if they ask long question, you can explain like that. And some of the MCQs I prepared. If you want, I'll share to this Panchajanya team. You can collect from them. So that is about total eyeball. So any doubt you can ask now. Thank you.
Thank you, ma'am. Thank you for this beautiful session. Everything was very neatly explained, and I hope it'll be benefiting many people. And actually, many have asked for the presentation also, ma'am. I'll be sharing it with them. And if there's any doubts also, I'll forward it to them, and you can revert back the explanation, ma'am.
Okay, Pratiksha. Thank you. Thank you so much.
Thank you, ma'am.
Okay.